Hi, my name is Gerds, and I'm Associate Professor of Medicine at the Cleveland Clinic at Prostate Cancer Institute. I'm here at the 2021 ASH annual meeting, and it's been a wonderful meeting, getting to see colleagues both in person and virtually over the last few days, kind of rekindling the passion for care of our patients, particularly those patients with myeloproliferative neoplasms. There's been a lot of great presentations over the duration of the meeting. Some of the scientific discoveries within MPNs have been very exciting, kind of trying to understand the biologic underpinnings of this disease, such as how p53 mutations play a role in disease progression, and how we might use single-cell analyses to better risk stratify patients with polycythemia vera. On the clinical observation side, there have been a number of really great abstracts presented of new therapies, particularly for myelofibrosis, looking at targets outside the JAK-STAT pathway. We've had things like hydroxyurea for a long time, as well as JAK inhibitors, but trying to look at different ways of targeting these diseases. For example, research was presented on a single agent study using a bromodomain inhibitor that showed significant clinical activity, positive activity for patients with myelofibrosis. There's another trial with a drug called selinexor, which targets a totally different pathway that certainly had some very interesting results and is leading to further exploration. One of the other themes at a session was better understanding an individual's risk for blood clots, particularly those patients with polycythemia vera. There were a number of abstracts in this session that said our classic model of risk stratifying risk for blood clots in PV is antiquated, which we all know it is. It's been around forever. Age and history, prior history of thrombosis, and concepts like using other blood counts, using JAK2 variant allele frequency burden, and these other things to kind of see if we can improve upon understanding who may have a blood clot in the future and who may not. Therefore, we can more correctly apply therapies going forward. And I thought that was a really poignant and kind of incorporated session. The last thing that was really kind of stuck in my mind is a discussion that wasn't part of any formal abstract session. As people are getting up and giving their abstracts, we're often kind of leaning over in the rows, talking to each other, both socially, but also about what's being presented. And one of the comments that's been stirring around quite a bit is about toxicity, which I think is an incredibly important topic. Many of these drugs that we give in clinical trials as well as in clinic have side effects. And often in these situations, you're very enthusiastic about this trial or about the results from this trial. In an abundance of enthusiasm, it's often said, well, this drug was well tolerated. And then you look at the actual numbers, 70% of patients had an adverse event, or 20% of patients stopped drugs due to adverse event. And I'm not sure if you asked a patient who was on that trial and experienced those things, is that really well tolerated to you or not? And I think it really makes us take a stop. Maybe we should take a step back and not use that term so flippantly, and really truly just say, these are the facts, ma'am. This was the adverse event rate. These were the number of people who came off drug because of adverse event, and try not to editorialize too much on it. Secondly, I think it's a true call for patient-reported adverse events, which has been a big push from the NIH and the federal agencies that regulate clinical research, but developing tools to accurately measure how toxic a treatment may be for them, kind of like a quality of life assay or a symptom burden assay, but specifically for side effects from a medication. So I think that was a clear message that we were all on the same page with as we viewed these abstracts. So again, a lot of great science, some new drugs coming to the clinic soon, or we all anticipate, and we saw updated results for those. But honestly, really the gem in the meeting for me was kind of some of these side conversations on how we can do better designing clinical trials and capturing the true essence of what treatment is like for patients.